today. Today is a very special Grand Rounds. It is the final in our series of Dream Speakers by our residents. And this year's intern class has selected Dr. Raymond Chung to be their Dream Speaker for Grand Rounds. And I also want to thank Dr. Chung for doing a roundtable later on this afternoon with our interns and residents. And so to introduce Dr. Chung, we have our own Dr. Jihad Ajaban. Thank you.
Thank you, Dr. Schnapp. Today, I have the great pleasure of introducing Dr. Raymond Chung, who was chosen by the Internal Medicine Residency PGY1 class to speak today as part of our Dream Speaker series. Dr. Chung was born in Madison and is no stranger to the Badgers. He began his illustrious academic career at Harvard, where he graduated as an undergraduate with magna cum laude. He went on to earn his MD from Yale Medical School, where he wrote a thesis on regulation of globin mRNA degradation. He completed his internal medicine training at Johns Hopkins and a fellowship in gastroenterology and hepatology at Massachusetts General Hospital, where he has served in various faculty positions since. He is currently professor of medicine at Harvard Medical School, the director of hepatology, and the vice chief of the gastroenterology unit at MGH. He has helped grow the liver center at MGH to the world-renowned institution it is today. He directs a GI physiology course at Harvard Medical School and serves as the program director of the Hepatology Fellowship Program. He is also the current president of the American Association for the Study of Liver Diseases. In addition to being a robust clinician, Dr. Chung is an exemplary scientist who has earned international recognition for his research in viral hepatitis. He holds multiple R1 grants for the study of hepatitis B, hepatitis C, and HIV infection as they relate to several facets of liver disease. He has been studying HCV since its discovery in 1989 and played a significant part in investigation of direct-acting antiviral treatment, or DAAs. The curative treatment of DAAs toward HCV represents a crowning achievement in medicine, and Dr. Chung has made great efforts in advocating its use and accessibility to all patients in need. He has won several awards and honors in his capacity as an educator, clinician, and scientist. His many awards include the MGH Research Scholar Award, the Bigelow Medical Service Award, and many, many others. He has authored close to 400 original articles, reviews, and editorials. He also serves as an editor for several journals, including the Journal of Infectious Diseases, World Journal of Gastroenterology, Liver International, Hepatology, and others. He has also served as a mentor to hundreds of fellows, residents, and medical students. On a personal note, I've had the great pleasure of collaborating with Dr. Chung and his lab and shadowing him on the wards while I was a graduate student back in Boston. He has inspired me to pursue hepatology and to matriculate to the physician scientist training program here at UW. He is proof of the profound impact physician scientists can have. So please join me in welcoming him back home and to the Department of Medicine.
Thank you. Thank you so much, Jihad, for that all too kind introduction, and I just I'm tickled by the honor and the recognition that you have all conferred on me with this invitation. This is something of a homecoming, as was described. I have a very few and embryonic memories of Madison, so it's great to visit again, so to speak. My birthplace. My father had earned his PhD. Speaking of scientists, his PhD in Madison. And so we've really come full circle here, and so there's something really quite fitting about all of this, quite honestly. For today's talk, I want to describe to you the remaining challenges for hepatitis C. As Jihad described, we've made breathtaking progress, but there are still several miles to go before we sleep. These are my disclosures, and here's an overview of today's talk. Really, I want to give a really brief recounting of how we got here. Specifically really describing the arc of what is really now, I think, widely accepted as a profound medical triumph. We'll describe even the early clinical dividends of the application of direct-acting antiviral therapy. We'll talk about the big challenges ahead, the HCV elimination agenda. And really, the gauntlet has been laid down to eliminate Hep C by the year 2030. Can we get there? And what about the prospects for a protective vaccine? We'll talk about that briefly. And there are still some clinical residual issues in persons who have or had chronic liver disease-related hepatitis C, even after cure. We have seen reduced rates of complications, including hepatocellular carcinoma, but not eliminated. And so we'll talk a little bit about the basis for that residual risk. And then we'll talk about opportunities, specifically the utilization of HCV-infected donor organs in uninfected recipients, a previously unused or underused resource that can now be thought of as a real opportunity in the really in the wake of direct-acting antivirals. So this is the scope of really the problem of hepatitis C, even as we've developed direct-acting antivirals. Fully 70+ million persons are infected worldwide, with another 2.5 million infected here in the United States. And as we'll discuss later, still fully half of these individuals have yet to be detected. HCV long ago surpassed HIV attributable mortality. This was about 15 years ago that the curves crossed and have really been spreading ever since. Although again, we expect that DAAs and their application will help bring that curve back down. It remains the leading indication for liver transplantation worldwide, and is still the leading cause of hepatocellular carcinoma here in the United States. So how did we get here? Well, over 25 years ago, Harvey Alter and his colleagues at the NIH had really described beautifully this so-called non-A, non-B hepatitis, which was really predominantly a post-transfusional hepatitis. But many efforts had been made to try to understand and identify the agent responsible. There was plenty of evidence to support that this was a viral and a transmissible agent. And so it was really through the efforts of Harvey and Michael Houghton at the Chiron Corporation that really led to the breakthrough that has really become known as the discovery of hepatitis C. And this was accomplished really through the painstaking effort of taking high titer plasma from infected individuals and extracting the RNA from that plasma and reverse transcribing it into cDNA, and then placing those cDNAs into a bacteriophage library, whereupon all of those DNA sequences could be expressed. And they were expressed in E. coli, and then blotted onto filter paper, and then exposed to the convalescent serum from patients who had had the clinical syndrome of non-A, non-B hepatitis. And ultimately, a clone was identified and subsequently re-expressed and recloned to generate what is now known as the hepatitis C virus genome. And that genome is demonstrated here. It's a member of the flavivirus family, sisters of whom include West Nile virus, yellow fever virus, and more recently Zika virus, all members of this family, which essentially encodes for it's a long RNA genome encoding a single long polyprotein. Shown here is the HCV polyprotein with its structural portion upstream and its non-structural portion downstream. And then ultimately, this polyprotein, as it's described, is cleaved by both host encoded as well as virally encoded proteases to result in a series of 10 mature peptides. And it was really through the work of Charlie Rice and many others that identified the molecular anatomy of hepatitis C virus, and ultimately to the proteins and targets that would culminate in the development of direct-acting antivirals. And so the life cycle of hepatitis C, as we understand it, is really critical to understand. It's really critical to understand how we got to cure through our understanding of this life cycle. And without going into great detail, I would really point out the fact that once the virus infects the cell, all of the action takes place in the cytoplasm, where that polyprotein essentially replicates the viral genome into new strands of virus in the cytoplasm through virally encoded replication machinery, including an RNA-dependent RNA polymerase. This is important because there is no DNA intermediate, i.e. hepatitis C has no reverse transcriptase function that allows it to be formed or at least take on a DNA intermediate that can stably inhabit the nucleus. Rather, that RNA genome is copied directly into new copies of RNA, and the virus depends on continuous replication for its existence. So it must replicate or perish. So this is the Achilles heel of hepatitis C virus. The fact that can we in fact apply potent inhibitors of replication and prevent emergence of resistance for a sufficiently long period to bring about extinction of the virus. Now, this is no small task because as well as not having a DNA intermediate, there is an error-prone polymerase that generates extraordinary sequence diversity as described by the characterization of 6 major genotypes worldwide, with marked sequence diversity between genotypes. And even within an infected individual, there is marked sequence diversity that exists. So the challenge then is to really find classes of therapy that work to prevent the emergence of resistance variants. And so this is really the strategy of taking these viral proteins, particularly a virally encoded protease, shown here as NS3, NS4A, the NS5B RNA-dependent RNA polymerase, and a third protein indispensable for both replication and assembly called the NS5A protein. So it is these 3 proteins that have really constituted the major targets for small molecule drug development. And really ultimately led to the description of several classes of therapy, combinations of which would have complementary non-overlapping resistance patterns, which would allow then multiple classes to be applied and provide potent suppression of viral replication, as well as prevention of resistance variants. At least that would be the theory. And so when this went into practice, when 2 or more classes of treatment could be offered, the results were nothing short of spectacular. So here, a nucleotide polymerase inhibitor known as sofosbuvir was combined with an NS5A inhibitor known as velpatasvir, both of which are pan-genotypic that cover all of the 6 major genotypes of hepatitis C, was given for 12 weeks for patients across the board, producing 97 to 100% rates of sustained virologic response. That is to say, clearance of HCV RNA 12 weeks after completion of a course of therapy. And this has been now subsequently demonstrated to be tantamount to cure of infection. So the breathtaking results with an all-oral combination regimen given for as little as 12 weeks and subsequently even more impressively 8-week regimens capable of producing, again, sustained virological responses in the vast majority of patients. Again, in this case, patients who had cirrhosis that was compensated were able to achieve extraordinary rates of success with an 8-week regimen of a pan-genotypic NS5A inhibitor, pibrentasvir, combined with an NS3 protease inhibitor called glecaprevir. So the science of the discovery of direct-acting antivirals against hepatitis C has really played out in really an extraordinary manner in producing essentially complete cure of a chronic viral infection of humans. And this is really the first such example. Now, in terms of treating the patient in front of you, you have a patient with chronic hepatitis C. The regimens and their durations continue to evolve. And what I would urge you to do, because of the very dynamic landscape of treatment, is to consult a living, breathing document here we call the hcvguidelines.org, a product of both the AASLD and the Infectious Diseases Society of America. And here you can take, essentially, customize the treatment experience to the patient in front of you, tailor them to the genotype of that patient, the prior treatment experience of that patient. Was that patient previously treated with peg interferon ribavirin? Are they cirrhotic, et cetera? And then a recommended regimen will be produced for your consideration. So I would urge you to consult this to manage the patient in front of you. So it's no surprise then that all of this work, again, started by Harvey Alter and Michael Houghton, and really catalyzed by Charlie Rice's work in the molecular virology of hepatitis C, culminated in their long overdue award last year with the Nobel Prize for the discovery and subsequent development of curative regimens for hepatitis C. So as we think about the dividends of DAA regimens, now that they've been in place for several years, we are already seeing returns on that investment. For instance, impacts of a sustained virological response on liver-related mortality has already become evident. So this is data from a Veterans Administration study of chronic hep C patients, most of whom were treated, about 37,000, and another 24,000 who were compared as untreated controls. And this was done over a period from 2002 to 2016. So most of these patients were actually treated with PEG interferon ribavirin, the predecessor to the oral direct-acting antiviral regimens. And one can see here that in terms of those who achieved sustained response, liver-related death rates were markedly decreased compared to those who did not. And when one looks at the regimen used to achieve those responses, it did not matter whether this was either accomplished with PEG interferon ribavirin or with direct-acting antivirals. The numbers are smaller, but clearly for those who achieved sustained response, there was a marked reduction in liver-related mortality compared to those who did not accomplish sustained response. So we're already seeing clear evidence of hepatic benefit for those treated and cured of hepatitis C. Well, it turns out there's also benefit that is beyond the liver, and this has been really a remarkable finding to see that there have been an impact of cure of hepatitis C on all-cause mortality. And this is actually seen not just in cirrhotic patients who are at particular risk for liver-related mortality, but even in non-cirrhotic patients for all-cause mortality. So this is, again, another Veterans Administration study of over 100,000 US veterans who had genotype 1 through 3 hepatitis C and had a FIB4 non-invasive parameter score of fibrosis that suggested that they did not have cirrhosis, a score of less than 3.25. Over 40,000 of these veterans were treated with DAAs with, not surprisingly, very high rate of sustained response, 97%. In multivariate analysis, the hazard ratio for all-cause mortality was markedly reduced by about 56% for those who achieved sustained response compared to those who did not. Further corroborative evidence came from a study in France in which 10,000 patients with a non-cirrhotic or early cirrhotic HCV disease were treated with DAAs, and a similar result obtained, namely a 52% reduction in attributable all-cause mortality seen in these patients. Really, a familiar theme, I think, is emerging that we are improving not just hepatic mortality, but all-cause mortality. And specifically, those outcomes include improvements in end-stage renal disease development, acute coronary syndrome, and stroke in those who achieve sustained response with direct-acting antivirals. So we're already seeing, again, the dividends accrue for the administration of DAAs. Not surprisingly, with the availability of DAAs, the World Health Organization issued really a call to arms in which essentially they declared that we should witness elimination of hepatitis C and by 2030. And by this, they meant, by elimination, the reduced incidence of acute infection of hepatitis C by 90% and attributable mortality to hepatitis C by 2/3. So these are ambitious goals indeed, but for countries that have systems that are amenable to this, we have seen, and coupled with political will, we've actually begun to see real traction take place. And particularly those countries that had the lever of single-payer systems. Here again, I think that the tenets of this will be the maximization of screening and case identification, the linkage of diagnosis of hepatitis C to care, and of course, the ready access to DAA therapy. And so, since the gauntlet has been laid down by the World Health Organization, we have already seen a number of countries really take up the challenge. And you can see here that this is a scorecard of countries and their performance in terms of projected year of elimination based on current trends of treatment. And you can see that some countries are doing extremely well, particularly many in Western Europe and Japan and Australia included here, and South Korea, single payer systems who have made the commitment to eliminate Hep C and meet targets. Still others really have been laggards, and I think most of the world has lagged behind, and the United States is no exception. So we are talking about an elimination goal at current rates that would only be met by the year 2050. So there's really much work to be done here in this country. Indeed, as one looks at the World Health Organization targets, again, displayed here for incidence reduction and mortality reduction, also diagnosis coverage of 90% and treatment coverage of 80%, we can see here that incidence remains our major problem. So instead of a reduced incidence of Hep C infection, we're actually instead seeing an increase in incidence of acute infection, and this trend has really been driven by the opioid epidemic. We have made real progress in treating those patients with chronic established disease, particularly those with advanced disease, in making a dent on liver-related death. So we're on track to meet that mortality reduction target, but in terms of eliminating incident Hep C, we have much work to do. And as I alluded to, that's really been driven by the opioid injection epidemic, particularly among young Americans. You can see here that the trend lines for both opioid use in those aged 18 to 29 and those aged 30 to 39 have been stark and dramatic, and in lockstep with increased incidence in acute hepatitis C infection. So we have really much work to do to curb the trends of incident hepatitis C. So in terms of thinking about our targets, I think for mortality reduction, diagnosis, and treatment coverage, we may be able to get to those before 2030. But again, we have really much work to do on incidence reduction in order to meet those WHO goals. So as we think about that and the cascade of care in which those individuals who have hepatitis C infection are diagnosed, their viremia confirmed by HCV RNA testing, undergoing disease staging, most importantly, being prescribed treatment and achieving cure, there has been a marked steep cascade of care here. And nowhere is that more evident than in that first step, the ability to identify those who are actually diagnosed. And we really, at this point, have only been able to diagnose half of those who are chronically infected. So half the epidemic remains beneath the tip of the iceberg, let alone accomplishing treatment and sustained virologic response. And so as we think about screening as really having fallen short, we need to go back to the fact that first we had risk factor-based screening until 2012, which was an abject failure in terms of case identification. Then baby boomer screening was implemented by the CDC in 2012. And those individuals really were thought to constitute the majority of the epidemic. That 80% of the epidemic resided within those born between 1945 and 1965. So at that time, 70% were thought to be undiagnosed, and we've now whittled that down to 50%, but we can and must do better. And so in acknowledgement of the younger trends in acute hepatitis C infection, the CDC has recognized that we need to push the envelope to really extend to all adults. And so that recommendation was endorsed by the U.S. Preventive Services Task Force. And so in place now for all of our patients is a recommendation for at least one-time screening for hepatitis C infection in adults between the ages of 18 and 79. And for those with ongoing risk factors, particularly injection drug use, regular screening, potentially annual screening in those patients, again, with ongoing risk factors. So another major aspect of really achieving elimination is to assure access to therapy. We initially, when the DAAs were introduced, we were all stunned by sticker shock in that initial regimens based on wholesale acquisition costs were approaching $100,000 per curative regimen. That number with competition and I think with outcry has been reduced, but is still quite expensive at $24,000 to $26,000 for a curative regimen today. Moreover, there are restrictions. You can see here on the map that there are Medicaid barriers to access, particularly here shown in the red, limited access to therapy for those on Medicaid, and restrictions on who can prescribe HCV therapy, in that many states still require specialists. And so the idea that that getting patients treated must reside in the hands of specialists has got to be disabused. There are very interesting novel models at work, particularly in states like Louisiana and the state of Washington, where there is a so-called Netflix-like subscription model under which a single bundled payment can result in as many courses of therapy as are needed for that particular jurisdiction. And we hope certainly that innovative programs like these will continue to flourish. One example of so-called microelimination of a system within the US that has demonstrated how to get things done has been the very same VA that I referred to earlier. And again, here the VA is as a essentially a micronation, as a single payer model that is implemented from a very early point in time, owing to the high prevalence rates among veterans, universal testing, and a commitment to universal access to DAA therapy, such that by the year 2020, we've already seen that of the 152,000 HCV infected veterans, 125,000 of them have been cured, which is really a quite dramatic example of the fact that this can be done. And so microelimination, I think, is an example that we hope can spread further into much more macro territory. And so as we think about elimination, we think about really several tenets as outlined by the Coalition for Global Hepatitis Elimination. These are simplification, in which patients can be not only tested but treated in short order, potentially all in one sitting, using potentially a point of care testing. This would be particularly effective in persons who inject drugs, and also in those with limited access, like low and middle income countries. The integration of HCV treatment with substance use disorders, which go hand in hand with the acquisition of Hep C, and primary care, along with the coupling of harm reduction, opioid substitution therapy, along with needle and syringe exchange, are going to be essential for stemming the spread of hepatitis C and onward risk transmission. And here again, we can talk about HCV treatment itself as prevention. Decentralization of the work to local communities, or even training more rural communities that have limited access, using video conferencing technologies like Project Echo to really train treaters wherever they might be to reach these patients and treat them where they live. And shifting of tasks, as I alluded to earlier, not just in the hands of specialists or even MDs, but advanced practice providers, nurses, and community health workers, in terms of offering these treatments. One study called the ASCEND study compared sustained response rates for nurse practitioners, primary carers, and specialists after everyone received a 3-hour training video. And among 600 patients, comparable sustained response rates were achieved between these groups of treaters. So it can clearly be done. I want to point out to you examples of simplification. This is a recently concluded and presented study from the AIDS Clinical Trials Group called the 5360, or Minimal Monitoring, or MINMON study, in which essentially an international study in 5 countries shown here was conducted using essentially a strategy in which there was no pretreatment genotyping. The entire prescription was handed to the patient at baseline, in this case, 12 weeks of sofosbuvir/valpattocin. No scheduled on-treatment clinic and lab visits, because these are well-tolerated regimens, and 2 phone contacts made during the course of therapy and follow-up. And in essence, this produced, for all comers in all countries, a 95% rate of sustained response with no serious adverse events that resulted in treatment discontinuation or worse. So this minimal monitoring approach is one way I think we can access patients for those who have limited access to healthcare facilities, and get them the treatment that they deserve. Integration-wise, it's possible to tackle the biggest beast of all, which is active injection drug users. This is a study known as the HERO study, which was funded by PCORI, in which patients, active injection drug users who are attending opioid substitution therapy clinics in 8 states were randomized to receive either modified directly observed therapy or randomized to a patient navigator who helped shepherd them through treatment. And these individuals were essentially, again, randomized to receive sofosbuvir or valproatovir for all comers. And what you can see here through the cascade of care, initiation, completion, and achievement of sustained response, both arms performed equally well. And in toto, about nearly 60% of patients achieved a sustained response. So whether accomplished through direct observed therapy or patient navigator, success can be accomplished in this extremely challenging group of patients. Now, this clearly, I think, can have a real benefit insofar as studies have shown that HCV treatment of patient groups that are at high risk of onward transmission to others can potentially function in and of itself as prevention. So this is a really compelling study from the Netherlands in which HIV positive men having sex with men who are at very high risk of HCV transmission were offered unrestricted access in the Netherlands at the beginning of 2015 to DAAs. So the number of acute hep C infections is shown here on the y-axis for genotype 1, genotype 4, and in the blue, all infections. And one can see a steady decline in the number of incident acute hep C infections in those attending these community health centers caring for these patients. And this marked decline in incident HCV infection, and can be viewed as strong evidence for the benefit of widespread administration of DAAs to this group of high-risk patients. So the notion of HCV treatment as prevention, I think, has credence, and I think will be very important for us to apply to our injecting drug use and other risk populations. Now, I do want to point out that even with curative DAAs, that no infection has ever been eradicated from the face of the earth without a successful vaccine. So I think efforts should continue apace for us to develop HCV vaccine. However, the challenges to development of vaccine are numerous, including the genetic diversity I shared with you earlier in the talk, and the fact that neutralizing antibody responses against the virus, typically speaking, are very feeble. So this is a real challenge for the generation of a protective antibody response. Nonetheless, turns out that a chimpanzee adenovirus-based strategy was applied a number of years back, together with a modified vaccinia boost approach, and this was found to be highly immunogenic in volunteers. And so a randomized controlled trial was actually applied to over 500 injection drug users in a number of communities. But unfortunately, this strategy, as you can see here in a study published just earlier this year in the New England Journal, failed to demonstrate protection against HCV infection, although you can see here that the peak level of viremia among those who are vaccinated was blunted compared to those who received a placebo. Unfortunately, this approach did not protect against the development of chronic infection. And so other approaches are being evaluated, including using multiple antigens, stronger adjuvants, and possibly spurred on by the success of the COVID vaccination program, the use of messenger RNA-based vaccines. So again, considerable work lies ahead for this strategy moving forward. So what about the risk of hepatocellular carcinoma? So it turns out that hep C, as a chronic viral infection of the liver, producing fibrosis and cirrhosis, increases the risk for hepatocellular carcinoma at about 1 to 2% annually among patients with cirrhosis. And initially, after DAAs were rolled out, among cirrhotic patients, there was an initial concern about a paradoxical increased frequency of HCC, but many studies have been performed since then and have not demonstrated a recurrence or occurrence risk of HCC in excess of rates that were observed with prior interferon-based treatments. Indeed, a meta-analysis of over 40 studies encompassing nearly 14,000 patients showed no difference after adjustment for follow-up time and age in terms of the risk reduction of DAAs for HCC. So indeed, what we are seeing is that cure of hepatitis C does result in reduction of HCC. From the VA, over 84,000 patients were treated DAAs, and their hazard ratio for the development of HCC among those at risk was dropped by over 70% in those who accomplished sustained response versus those who did not. So the good news is that we reduce complications, clinical complications, including hepatocellular carcinoma, among those who are successfully cured of hepatitis C. But we do not eliminate that risk insofar as there still remains a residual group of patients who do go on to develop HCC. And so you ask yourself, this is not an integrated virus like hepatitis B. So this is not insertional mutagenesis. This is a virus that has really no inserted material in terms of direct genomic carcinogenesis. Rather, there may be other mechanisms at work, including the loss of immune surveillance that may have been keeping early tumors at bay, and then they're removed with cure, and potentially the tumors may express themselves. Direct genetic changes that are not insertional, but maybe a result of genotoxic effects of oxidative stress and reactive oxygen species, virus-induced signaling alterations, including proliferative and anti-apoptotic pathways, such as those shown here, like Wnt and EGF and P53, the impact of cofactors that persist in patients with hep C, fatty liver, alcohol, iron overload, and hepatitis B virus all must not be discounted here as possible contributors. And intriguingly, I think epigenetic changes that might occur in the context of chronic hepatitis C. And as far as epigenetic changes are concerned, it's worth just sharing with you just some very intriguing studies that suggest that there are epigenetic persistent changes even in the context of a cured hep C infection. So the question here is, are there scars that might drive the alteration of transcriptional programs even after removal of virus? And so in this regard, it's worth again pointing out that transcription occurs from DNA that is tightly wound into histones, and it turns out that there are alterations of that DNA that enhance the access of the transcriptional machinery to that DNA of interest. These include methylation, which tends to suppress transcription, and acetylation of histones, residues within histones, that are permissive for transcription and could theoretically upregulate HCC driver genes. At least that would be the hypothesis. And so a group in France studied this using chromatin immunoprecipitation, in which essentially DNA bound to specific histones that harbor this acetylation substitution or modification were sequenced. And it turns out there are a number of differentially modified genes, including high-risk genes that could potentially drive HCC. And I want to focus your attention here on HCV-infected individuals. The darker, these each represent genes here in the rows. Individual patients are shown here in the columns. And what one can see here is that among HCV-infected individuals, again, grouped by fibrosis, earlier fibrosis here on the left, later fibrosis or advanced fibrosis here on the right, one can see that in those with more advanced hep C fibrosis and cirrhosis, there are the darker colors here indicate more histone acetylation, and so an upregulation of theoretically of these genes may be occurring, and many of these are HCC, potentially HCC driver genes. So interestingly, if you look at those who are DAA cured, there appears to be some improvement in the acetylation status of these individuals, particularly for those who have more limited fibrosis, shown here F2 and F3. But among those with cirrhosis, F4, we do not see any reversal of these changes. So there appears to be a persistence of these epigenetic changes among patients who have more advanced fibrosis. Looked at in another way, there are transcriptional changes of specific genes. This was demonstrated by our collaborators, Eugen Hushida at the University of Texas, Southwestern, who really demonstrated that there are a number of genes in this 186 gene prognostic liver signature that predicted the subsequent development of recurrent HCC among patients who had had an HCC resected. And there are a number of genes called poor prognostic genes, upregulation of which, shown here in red, are associated with high recurrence rates, and good prognostic genes, downregulation of which, shown here in blue, was again associated with a high rate of progression to HCC. So it turns out that if you look at these gene signatures and those who are treated with curative therapies, but who subsequently go on to develop HCC, what we see here in this modified or normalized enrichment score is that in those, if one looks at the high-risk gene signatures and you look at sustained responders, those who did not get HCC had an excellent suppression of these high-risk signatures, whereas there was a lesser or blunted degree of suppression in those who, yes, accomplished cure, but still went on to develop cancer, suggesting that there was only partial reversal of that signature. And correspondingly, we see the same thing with the low-risk genes, similar lack of full reversal of those signatures in the context of those who go on to develop HCC. And that's true of both non-responders and sustained responders, as shown in the slide. So there is this notion then that potentially epigenetic scars in the face of chronic hep C infection may leave their mark at the transcriptional level and lead to a residual persistent risk for HCC. So what does that mean practically? It means that for those patients with advanced fibrosis, namely bridging fibrosis cirrhosis, stage F, stage 3 or 4 fibrosis, surveillance for HCC remains essential even after cure of hep C infection with DAAs. So our work isn't done with these patients. We should continue to screen them with every 6-month ultrasounds or other imaging modalities together with serum alpha-fetoprotein testing. Really, further study is going to be necessary to establish when screening can be relaxed in these patients, because that risk has been shown to persist even up to 10 years after cure of infection. And it will be important to ascertain and to minimize cofactors that may contribute to that HCC risk, including ongoing alcohol use, the persistence or presence of fatty liver, and hepatitis B co-infection, to name several. So I want to close by considering some of the other opportunities that the DAA era has really endowed us with, and really one of them is the really previously inconceivable notion of using an infected donor organ in uninfected recipients. We have been able to take HCV infected organs and put them in HCV infected recipients and treat those infections effectively. But the idea of introducing an infection, donor-derived infection, in an uninfected recipient had been heretical until now. This has been driven, of course, by the worsening of the donor organ shortage and the increasing wait time for individuals waiting for solid organs of all sorts, and coupled with an increased supply of HCV-infected donor organs, if you will. 30% of overdose donor deaths are HCV-infected, again, in many ways reflecting the trends that I shared with you earlier in this talk. And, of course, the availability of curative pan-genotypic direct-acting antivirals make this unthinkable prospect now thinkable. So we can think about administering these regimens either reactively or preemptively in patients who are undergoing transplantation, and could be given potentially even during hepatic or renal impairment, insofar as these regimens can be potentially safely given during those periods with few drug-drug interactions. There is a precedent for donor-derived infections being used. CMV, for instance, CMV positive donors being used in CMV negative recipients with prophylaxis using antivirals for some period of time in those patients, and even using anti-Hep B core positive or latently HBV infected donor livers, again using indefinite antivirals in those patients, have also been done successfully. So the proof of concept of this, particularly I think was evident in kidney recipients, where there are very high discard rates for HCV infected organs running up to the introduction of DAAs. So the first proof of concept came from a study called the Thinker trial, in which patients received NAT or HCV RNA positive kidneys, 20 such patients, and at this time, they were rapidly genotyped and found to be genotype 1. If they were genotype 1, they received a genotype 1 specific regimen called elbasvir and grazoprevir that could be given with kidney impairment for 12 weeks and slightly longer if resistance-associated variants were present. And in this study, the first appearance of viremia triggered this treatment. These patients accomplished 100% rate of clearance of Hep C with excellent allograft outcomes. And we and other centers have also subsequently conducted studies demonstrating success with a preemptive regimen in which this very same treatment, elbasvir grazoprevir, was offered to these patients on call to the operating room once an HCV-infected donor organ was available, again with excellent rates of success. More recently, we've completed a trial, a multi-center trial, using a standardized regimen of glecaprevir pemetrexed given for 8 weeks in individuals just after kidney transplantation. This was a 7-center study of 30 patients, and I would focus your attention here on arm 1, shown here in the upper portion of the slide, 8 weeks with a follow-up period. And what was seen in this study was a marked clearance of viremia by 4 weeks in all participants, and a sustained virologic response in all comers, 30 out of 30. It was very well tolerated, and these are the allograft functions shown in the aggregate of all those patients. Excellent allograft function accomplished in all 30 patients. What about other organs? We have developed a very robust experience with both hearts, lungs, kidneys, and livers, and all 4 organs have shown similar proof of concept. And this is a study that we conducted about 2 years ago, in which patients undergoing heart transplantation were offered, again, a preemptive strategy of glecaprevir pemetrexed for 8 weeks, and then with standard monitoring thereafter. Turns out that this was for NAT positive donors. For those who are NAT negative, we were able to observe them and treat them in the event of viremia. And these are the data from our first 25 patients, in which 20 were NAT positive and 5 were NAT negative. Long story short, all 25 accomplished clearance of viremia, which was very brief, using a preemptive strategy. And I think, moreover, I think this was an important dimension of the study. There was a marked reduction in wait time for these hearts. Most of these patients were in the hospital on ventricular assist devices or balloon pumps, sitting in CCUs, waiting for hearts. And so the wait time for those who agreed to consent to the HCV positive protocol was dropped from 113 days for those who did not to about 20 days for those who did consent for HCV positive hearts. So really marked improvement in outcomes as well, and certainly as well as access to treatment is possible with such a strategy. And then perhaps pushing the envelope in even further, this is an example of a study in which 30 recipients from 18 HCV infected donors, heart, lung, and kidney, these are non-liver recipients, were offered an extraordinarily brief regimen of 1 week of glecaprevir pemetrexed on call to the operating room, coupled with a putative HCV entry inhibitor, ezetimibe, which actually blocks cholesterol transport, but is also thought to block HCV entry. And in this group of 30 recipients, all 30 accomplished sustained clearance of hepatitis C. Similarly, reducing glecaprevir and pemetrexed to 4 weeks in a kidney transplant cohort was also accomplished recently with 100% sustained response rate. So we're continually shaving off duration and pushing the envelope in terms of demonstrating success of this concept, particularly in non-transplant liver transplant recipients, where the donor organ does not actually harbor the infection. So in summary, I hope you can appreciate that we have come from discovery to breathtaking cures in just over a quarter century of research. And this really represents an extraordinary first example of cure of a chronic viral infection of humans. This represents a triumph of both molecular virology as well as rational application of combination antiviral approaches in order to produce the kind of sustained responses we're witnessing. We are already realizing in the short time DAAs have been around, in about 5+ years, clinical benefit is being realized in both the form of hepatic and all-cause mortality and reductions in HCC. Elimination can now be envisioned, but now that the science has been solved, the real problem is implementation. Implementation of cure by identifying cases and applying linkage to care to those cases, as well as, of course, the development of a preventive vaccine. There is a residual risk for HCC for those with advanced fibrosis, even those who are cured of Hep C, likely driven by epigenetic and transcriptional changes, and that we should apply surveillance in those patients until a safe to stop signal has been defined. And I think the use of HCV-infected donor organs in uninfected recipients represents yet another downstream benefit of the DAA revolution in that it is safe, effective, and feasible, and really has now been adopted by transplant centers as a standard approach to managing our patients. So I want to thank you again for the privilege and the invitation and the honor of being your speaker today. And again, thank you for your attention.
Thank you very much. It really is a remarkable story for someone who remembers talking about non-A, non-B hepatitis to come to defining it and finding a cure for it is pretty remarkable in one's lifetime. So the first question from Dr. Lucy, and actually I had the similar question. You talked about the signature patterns of the epigenetic changes that you see for those who are at risk for HCC. Where are we in terms of developing that as a prognostic tool for risk stratification for patients? Step one, and then question two is there work being done on trying to modify, reverse those epigenetic changes?
Great questions, both of them, and I'm glad you both asked them. So to the first question, so what I shared with you was really a signature that was based on liver tissue. This was originally derived from studying the surrounding tissue around a tumor and its predictive value for subsequent tumor recurrence. And subsequently, that signature has been shown to predict incident HCC. It's been also shown to predict decompensation and hepatic mortality in patients with chronic hepatitis C. And moreover, has been shown to predict HCC and liver outcomes in patients with other etiologies of liver disease. So this seems to be a fairly common pathway across etiologies. Now, but the question is, how do we readily access that signature? This is still a research tool that depends on liver tissue, because this is really looking at a transcriptomic soup of multiple cells in liver tissue. So Eugene Hoshida, our collaborator and colleague at University of Texas, we thought about the development of a corresponding plasma-based test. And so from those 186 genes, a number of them actually encode for secreted proteins. And so a painstaking sort of analysis was done to sort of identify those proteins that would be predicted to be secreted to potentially constitute a bundled signature, a multiplex type of signature existing as circulating proteins. And so this has actually just been submitted and accepted for publication, but a so-called prognostic liver secretory or secretome signature has been developed. And so our hope here is that PL-seq, as we call it, will be able to be applied in a much more tractable way across populations to identify those potentially regardless of etiologies at risk for HCC, including those HCV cured patients after after DAAs and assessment of persistent risk. To the other question, which is I think the $64 question of how do we modify that risk? Well, I mean, we've already seen that the cure of an infection can modify the risk, but we still need to do better than that. And what we have done, again, in conjunction with our colleagues, Eugene Hoshida, is we've actually shown, at least in the laboratory, that there are a number of compounds that could potentially modulate that risk in tissue culture, and these include some commonly used agents, including statins and possibly even aspirin. Right, and so we also have buttressed this with epidemiologic data showing that the use of statins. Tracy Simon from our group demonstrated in a study that we did with colleagues in Sweden that it turns out that lipophilic statins like atorvastatin or simvastatin are associated with a decreased risk of HCC in populations of patients with chronic hepatitis C and chronic hepatitis B compared to, say, hydrophilic statins, as it turns out. And we are embarking on chemoprevention trials of statins to evaluate both modification of the signature, as I alluded to, as well as ultimately down the road reduced clinical signals in terms of reduced frequency of HCC. So the signature approach, I think, is one that is that invites the objective evaluation of chemopreventive strategies that because of its power as a surrogate marker for the development of HCC. So we're very eager to embark on those investigations. Thank you for asking.
Great. Another question, is it important to begin hepatitis C treatment soon after diagnosis, or can you monitor? And what's the natural clearance rate for people for the virus?
It's an excellent question. So, I didn't get a great deal into the spontaneous resolution rates, but Hep C has a marked predilection for chronicity, and so it's thought that the chronicity rate is largely somewhere in the 75 to 80% range after exposure to infection. But I think there's evidence that we should treat individuals as early as we diagnose them. I mean, first of all, for those who are in risk groups that are at risk for transmitting the epidemic, it's very important for us to treat those patients early. It's the acute phase of infection that is associated with the highest viral loads and the highest rate of transmission. And so an argument I think can be marshaled to treat even acute infection, even before you wait for spontaneous resolution to occur. We should probably treat those individuals to reduce onward risk of transmission at a minimum. But anyone, even the chronically infected person who comes to attention, they've had it for years and then come to attention, there is no excuse for not treating them at that moment in time. We have curative strategies as brief as 8 weeks that can get them to reduce their subsequent downstream risk, particularly if they're non-cirrhotic, reduce all of their downstream clinical risks. And there's really no excuse for us not to apply a test and treat approach to these patients. And this is really the only reasonable way that we can think about an elimination strategy. So no deferrals. We should be treating right up front.
Perfect. And what is the work on pre-exposure like prophylaxis for HCV in IV drug users?
Yeah, that's a really interesting question. This has not been a tested concept. I think this is the problem. Quite honestly, is that the DAA regimens are still not extraordinarily accessible from a cost and access vantage point to apply a PrEP strategy to patients who are at ongoing or practicing ongoing risk behaviors. They're not tenofovir, and I think that I think we could potentially envision a day where that might be possible if we can get ready access to inexpensive courses of treatment, it might be conceivable at that point in time to think about applying that to those who are active users. But the other flip side argument here is that there is a curative strategy, and this is the argument against post-exposure prophylaxis for that matter as well, which is that even if you were able to prophylax, the question then becomes, can we just simply identify and monitor and jump on those patients early enough, and then apply strategies such as were applied in the HERO trial to get on top of those patients the minute that hepatitis C is ascertained, and then try to prevent onward transmission. It's an intriguing idea, and one that might be worth testing, I think, in when these treatments become, I think, much more widely accessible to all.
Great. Well, we're out of time. I want to thank you, and I want to hand it over to Dr. Ajaband for another. Thank you.
Yeah, thank you so much for coming, Dr. Chung, and making time for us.
Absolutely. It was my pleasure. And I look forward to meeting some of you later today.
All right. Take care, everyone. Bye-bye.
Bye-bye.